6 studies comparing individual education to usual care, and they actually noted that from this review there was no improvement. Ours did the same 6 months of individualized diabetes self-management education, and there was also no improvement. However, for this Cochrane review, for the subgroup analysis that had a HbA1c of above 8, and ours did, they actually had shown that there was an improvement. So we tried to find a few reasons why ours didn't, and those are some of what we came up with. But even just to add a few others, that similar studies, or some that showed positive or negative outcomes in terms of the results. We looked at the Desmond trial in the UK. It was an RCT. After 12 months of follow-up, in terms of the HbA1c, there was a reduction. And even in terms of the behavioral outcomes, there was still a positive change. But this was a longer duration. But remember, earlier, I didn't think that mine would necessarily give me negative results due to the duration. This was another study from the UK. It was a cluster randomized trial versus 6 months delayed intervention for the control group. After 6 months, there was no significant change in any of the outcomes, but there was a reduction in the diabetes-related distress score after the same duration. Another study done in Sweden, it actually showed that even after a longer period of 12 months, there was still no significant change in the HbA1c or the body mass index versus the control group. But after 12 months of follow-up, there was improvement in confidence in terms of the diabetes knowledge. Okay, so what did we think about this? First of all, let's try to look at a few limitations. What the diabetic educators were offering, we were not able to assess them. There was no one time that any of my colleagues and I who were part of the study sat down with them to look at the intervention they were providing. They were just given a standard Aga Khan diabetes educator's sheet to follow and try to tick through some of the things that they educated the patient about, so that we did not really evaluate what they were offering. Other qualitative issues, as you know, that diabetes education may not only have a biomedical outcome improvement, but in terms of other things, I did not assess that. And of course, other confounders to the learning process, motivation, emotional, whether they had good family support or not, I did not assess that. And other things that came out from, some of my reviewers were did the doctors at the family medicine clinic, now that they were not blinded, did they maybe seem to do a bit more than what they would usually do in their usual consultation just because there was a study going on? Well, I'm not very sure of, but that's a potential confounding factor. So, being a family physician, first of all, the conclusion, we did not really see any statistically significant improvement in terms of the glycemic and metabolic control. So, are we able to conclude that a DSME education may have, limited additional benefits above and beyond what us family physicians offer in trying to manage chronic illnesses, but to probably have more solid evidence of this, we would definitely need to further develop this study or do some to explore the qualitative aspects in terms of diabetes knowledge and self-care activities, particularly in the primary care setting. Thank you.
So without further ado, I'd like to invite Dr. Jamil, who is a current resident at the Moi Teaching and Referral Hospital, whose main interest is cardiology. So we'll see what he has to offer to us.
Good afternoon. And this is actually my study for MMed internal medicine thesis. And we just concluded it earlier this year. So the study was titled Vitamin D, Beta Cell Function and Insulin Resistance among patients with type 2 diabetes at Moi Teaching and Referral Hospital, Eldoret, Kenya. So these were our operational definitions. Type 2 diabetes were patients who were being followed at the type 2 diabetes diabetes clinic at Moi Teaching and Referral Hospital. So we did not go and confirm the diagnosis. These were patients who were already on follow-up. And renal insufficiency was defined based on a GFR of less than 60. And the calculation was through the CKD-AP formula. Impaired liver synthetic function was defined using serum albumin levels with a threshold of 35 grams per liter, and insulin resistance was defined using the homeostatic model of assessment, insulin resistance, and the threshold that we used was a level of 2. So anything above 2 was defined as insulin resistance. Beta cell function was defined using the disposition index, and we used a threshold level of more than 50 to define normal disposition index or normal beta cell function. So a little bit on background information. I think we all know that the prevalence of type 2 diabetes is increasing globally, and the traditionally risks attributed to the increasing prevalence has been sedentary lifestyle, an obesogenic diet, and obesity against a backdrop of genetic predisposition. But recent epidemiologic studies have shown that there is a link between vitamin D deficiency and the risk of type 2 diabetes. So this was initially demonstrated in animal studies, where they showed that vitamin D deficiency resulted in attrition of pancreatic beta cells and decreased secretion of insulin from mice which had vitamin D receptors knocked out. And later on, there were some epidemiologic studies which were done, but key studies that are in support of this association are two large population-based epidemiologic study, which are conducted in the US based on the NAINS 3 survey. And they showed that vitamin D deficiency was significantly associated with the risk of type 2 diabetes. This was further demonstrated by two cohort studies, one which was done in England and another one which was done in Finland. The English study followed out patients for 10 years, and the Finnish study followed up patients for a period of 17 years. And in both studies, vitamin D deficiency predicted future hyperinsulinemia, future hyperglycemia, and incident type 2 diabetes. So evidence base for the association of vitamin D deficiency and type 2 diabetes remains weak in African American populations, and data from sub-Saharan Africa is limited. And this is despite there being racial disparities that are being described in studies to suggest that there are differences in the mechanisms that underlie dysglycemia and onset of type 2 diabetes among the various races. For instance, in a case report and a case series that was published in the US, they demonstrated near resolution of type 2 diabetes among a group of African American patients who were subjected to therapeutic improvement of beta cell function. This was also later on demonstrated by a meta-analysis of several studies, which was published in 2013, where they demonstrated that there is a hyperbola relationship between insulin sensitivity and insulin secretion. And in addition to that, they also showed that the different racial groups occupy different stability points along that curve, such that in Asian populations, they have a more predominant insulin resistance driving their dysglycemia, whereas in black populations, they have more beta cell insulin secretory defect that drives their dysglycemia, and sort of a balance of the two in Caucasian populations. So in light of that, cognizant of the fact that there are multiple pathophysiologic factors that are usually at play as far as type 2 diabetes development is concerned, and therapeutic efficacy is usually not sustained in the long term when we are treating patients with type 2 diabetes. So we saw the need to better define the dysglycemic abnormalities within our population and understand the nature of this association between vitamin D deficiency and type 2 diabetes within our population that is being demonstrated in studies that are conducted elsewhere. So that was the main justification for doing this study. So this was our research question. What are the levels of serum 25-hydroxyvitamin D, degree of insulin resistance, and degree of beta cell function among type 2 diabetes patients at the Moi Teaching and Referral Hospital? And how does 25-hydroxyvitamin D correlate with insulin resistance and beta cell function? Our broad objective was to determine the 25-hydroxyvitamin D levels insulin resistance and beta cell function among type 2 diabetes patients at the MTRH Diabetes Clinic. These were our specific objectives: to determine the levels of 25-hydroxyvitamin D among type 2 diabetes patients, to determine the insulin resistance level, degree, of insulin resistance among type 2 diabetes patients, to determine the degree of beta cell function among our type 2 diabetes patients, to determine the correlation between levels of serum hydroxyvitamin D and degree of insulin resistance, and to determine the correlation between levels of 25-hydroxyvitamin D and degree of beta cell function. So our study was conducted at the MTRH Diabetes Outpatient Clinic, and our study population were patients with type 2 diabetes who are seeking services at that clinic. We employed a cross-sectional analytic study design, and we used a simple random sampling technique. We had a sample size of 124, and this was arrived at using the Fisher's Z transformation formula with a correlation coefficient between vitamin D deficiency and insulin resistance assumed at negative 0.25, and insulin sensitivity, assumed at negative 0.25. That sample size powered our study at a power of 80% with an assumed alpha rate of 5%. So this was the inclusion criteria. Cases which are on type 2 diabetes cases which are on follow-up at the diabetes clinic, and we only recruited adults above the age of 35 years. So we excluded patients who had evidence of diminished liver synthetic function because of the conversion of cholecalciferol to 25-hydroxycalciferol at the liver. And then we also excluded patients who had impaired renal function, because this would have also had an impact, would have affected, the vitamin D physiology. And we excluded patients who are on exogenous insulin therapy, patients who are on vitamin D and calcium supplements, and patients who are on thiazolidinediones. So 25-hydroxyvitamin D was measured using an enzyme immunoassay kit, and we used the monobind AccuBind kit. And serum insulin was also measured using an enzyme immunoassay kit, and we used a monobind AccuBind kit. Blood glucose was measured using a point-of-care kit, that specifically the Abbott Lifestyle machine. These were the measurements that we calculated. HOMA B, which is for homeostasis model of assessment beta cell insulin secretion, was used to estimate insulin secretion using the linear formula that is provided there. And HOMA IR for homeostasis model of assessment insulin resistance was used to estimate insulin resistance using this mathematical linear formula as well. And the disposition index was used to estimate beta cell function. And the disposition index is the product of insulin secretion and insulin sensitivity. So that was the inverse of insulin resistance multiplied by the HOMA B. Yeah. So we use interviewer administered questionnaires for data collection, and data collection forms to collect data. And this data was entered into Excel and later on analyzed using the ARCO software. So categorical and continuous variables were summarized using proportions and mean with corresponding standard deviations, median with corresponding interquartile ranges. The relationship between vitamin D, insulin resistance, and the disposition index was explored using scatter plots and Loess curves. They were found to be non-linear, so we did natural logarithmic transformation of insulin resistance and disposition index, which were the dependent variables. And then we went ahead and did a linear regression model and computed the Pearson's correlation coefficient to assess the effect of vitamin D on insulin resistance and disposition index. Our study, we got ethics board approval, and we also got permission from MTRH to conduct the study, and all patients who were recruited into the study provided an informed consent. So these are the results. So we screened 287 patients. 87 were excluded because they met the exclusion criteria. And then 200 patients underwent, so these ones were excluded at chart review stage. 200 patients underwent further testing for renal and liver function, and we excluded 72 because they had either renal impairment or liver function impairment. So we were left with 128 patients who were recruited into the study. Our patients had a mean age of 56.2, and we had a male to female ratio of 1:1. The mean BMI was 26.9, and only 30.6% had, using JNC8 guidelines, hypertensive range BP. And the median vitamin D level was 16.0, and median fasting blood sugar was 6.3. Most of our patients were on metformin at 76.6%, and a number, like 38.3% were on sulfonylureas, and almost all of them who were on sulfonylureas were using glibenclamide. These are the other drug profile for the patients that we had recruited into the study. So this was the distribution of vitamin D. We had 71.1 patients had deficient level vitamin D, defined by levels of less than 20, and only 7.8% had sufficient levels with levels of more than 30 nanograms per ml. The median HOMA B was 84.9. The median HOMA IR was 2.3, HOMA insulin resistance, with normal ranges between 1.5 and 2. And the median disposition index was 25.5, with normal ranges of 40 to 50. So the relationship, we did not find any significant relationship between vitamin D levels and insulin resistance. It was non-significant, and the line is almost flat. However, we did find a positive, albeit weak, relationship between vitamin D levels and the disposition index, with a correlation coefficient of 0.21. So this study demonstrated a high prevalence of vitamin D deficiency among our patients who have type 2 diabetes. And it was rather odd, considering we live in a tropical country with sufficient sunlight all year round. But then similar findings have also been reported by another study. This study was quite similar to ours, and it was published in late 2017. It was conducted in Ghana. And however, they found a much higher prevalence of vitamin D deficiency in their type 2 diabetes patients of 92.4. Of note is that in both studies, the mean BMI was quite similar. They had a mean BMI of 25 in their study. We did not have a control arm. The Ghanaian study had a control arm to ascertain levels of vitamin D within the normal population. But there was a study which was done in 2013 that looked at vitamin D levels in the natural life cycle of individuals of East African descent. Indigenous in East African population. So they recruited patients from Nilotic, Bantu, and Kushite communities. And what they found was a mean vitamin D of 42.46 nanograms per ml, to suggest that in the healthy population, vitamin D levels are within normal ranges. We found relatively low levels of insulin resistance with a median HOMA IR of 2.3, which tends to almost overlap with what has been reported in healthy populations. For instance, in a study that was done in England, they tested insulin resistance levels in individuals in African immigrants, and what they found was a range of 1.76 to 2.03. But then there's a study which was conducted in Nigeria. They looked at women with type 2 diabetes, and they found a very high insulin resistance level of 9.4. But the difference between the Nigerian study and ours is that they had a mean BMI of 33. So the population was slightly more obese compared to our population. Both our study as well as the Ghanaian study did not find any significant correlation between vitamin D levels and insulin resistance. But this has been described in studies conducted among Asian populations and Caucasian populations. So our assumption is that probably insulin resistance is not a predominant contributor of dysglycemia among our patients. With regards to beta cell function, we found a low disposition index, a median of 25.5. And comparing it to studies that have been conducted in Caucasian and Japanese populations, where they found ranges of 37 in the Japanese and 40 in Caucasian populations, this is quite low. And of note is that we had a mean age of 56.2. In the Caucasian study and the Japanese study, the mean age was above 65. So even accounting for age-related attrition of beta cell mass, they still had higher disposition index compared to our population. The Ghanaian study did not find any positive correlation between the beta cell function and vitamin D levels. However, they did not use disposition index. And the disposition index is a better estimate of beta cell function in that it gives an estimate of insulin secretion relative to the level of insulin resistance. The Ghanaian studies only looked at HOMA B without calculating the disposition index. So my assumption is that probably that's why they did not find a positive correlation. What this suggests is that beta cell dysfunction, a blunted beta cell function, is a predominant defect that drives dysglycemia within our patients, among our patients with type 2 diabetes. This study had several limitations. One, it was a cross-sectional analytic study. That means it harbors the limitations which are inherent in that study design. We could not ascertain causality or reverse causality. And secondly, by only looking at fasting levels of insulin and blood sugar, we were only able to determine basal level disposition index. We cannot make conclusions with regards to postprandial beta cell function. For that, we would have needed dynamic studies or do an OGTT during the study. So in conclusion, we concluded that beta cell dysfunction is a predominant dysglycemic defect among our type 2 diabetes patients seeking care at the MTRH Diabetes Clinic. And vitamin D deficiency is prevalent among these patients. And the deficiency state exhibits a low positive correlation with beta cell function. Sorry, that's not, sorry. With beta cell function, not dysfunction. And that there was no observed correlation between vitamin D status and insulin resistance. So we came up with the following recommendations. The therapy for type 2 diabetes within our setting should be aimed at beta cell preservation, and we should screen for vitamin D deficiency in our type 2 diabetes patients and treat accordingly. And we did not find a strong relationship between serum vitamin D levels and insulin resistance, and therefore, as well as beta cell function, and therefore do not recommend supplementation for this indication. This was actually out of the scope of our study. And I'd like to acknowledge the following and thank KDSG for allowing me to present this study here. Thank you.
Dr. Jamil, I'm just curious about your BMI of 26.9% is rather low for our usual Kenyan population. So what is it, the tribes you're serving, or what did you think about that as a median HbA1c? I thought that was very interesting.
Yeah, it was, it's quite unusual, but we've been seeing rather lean patients with type 2 diabetes who have, another unusual observation is high insulin requirements when we're initiating them on insulin as well. And funny enough is that within Eldoret itself, in the private sector, we now see the classical type 2 diabetes patients who are obese and have significant insulin resistance. So this was actually one of the initial observations that sparked me towards doing this study and and document that indeed insulin secretion is a significant defect in this population of patients that we are seeing. Some of them are even having a much lower BMI of less than 25, like within normal range BMI, and they have type 2 diabetes as well. And the other reason why we excluded patients below the age of 35 is we just wanted to make sure we are not recruiting patients who have MODY. Yeah, that sort of, yeah.
Doctor from Aga Khan, it's curious that you had a very big dropout of patients on whom you had contact, and you say that you have no idea why they dropped out. I think you must tell us, because for young research scientists, that is a bit worrisome. These are patients that you are in contact with, and yet a big population did not show up. Some observational studies on diabetic control in Kenya in the past has shown that more than 2/3 of our patients, even in the best centers, the glycemic control is not optimum. Internationally, even in the very best of the countries, 1 out of 4 are not well controlled. And there are studies that have shown that glycemia and BMI seem to go together. I didn't get quite clear whether you managed to control for BMI, because in some of the large studies, it was shown that patients with a higher BMI tend to have poor glycemic control. So, did you control for BMI?
We tried to do as best as we could to follow them up, but I guess patients are patients. Sometimes, despite the most effort that you would do, they still don't show up, despite the fact that even within this study, the services that were being provided were actually free of charge. So, I mean, maybe social factors, as I'd said of my slides there, some moved out of town, some relocated. I think there was just some of the things that we as human beings could not really control for. Number 2, I think for the second question was, were we able to control for the BMI? Not really during this study. What we had hoped for is that with the intervention, with the self-care behaviors that they were being told, that it will obviously show a change in not only the HbA1c, but also the BMI. Those were part of my secondary outcomes. But unfortunately, the change that we showed was not statistically significant between the two groups. Maybe the duration of treatment or follow-up was short, probably, yeah.
My name is Beatrice Chesire. I am a resident in Moi University. I am doing obstetrics and gynecology. So in the morning session, I was very interested because they're talking about the gestational diabetes and also the care of the neonate. So I learned a lot, especially on the glycemic control and how to do it in a very structured way, and also the immediate things you would worry about a neonate, and also on the pregnant woman, how to take care of them during the pregnancy and also during the delivery. So as we went on to even the patient experience, it's always good to find out like what our patients think about us, about our care, and how they take it positively, and how they just generally look at this big disease, a chronic disease they'll have for quite a long time. Especially the type 1 DM patients. It takes, at whatever point they're diagnosed, it's a lifetime disease. So it's good to find out like exactly how they're doing. So I was excited about our patient. At least she knows almost everything that concerns glycemic control, and also generally what she really needs to worry about. And when we progressed, we continued to learn more about the diabetic foot. That is something I even tried doing a research on. I did something on diabetic foot care, but I was a student, so I'm sure I didn't publish it. I didn't do anything with it. I don't even have the data now, so so it's gone. I wish I did something good at that time, because it's quite around 2010, and I did a lot of work, though I just didn't know what to do with all that data. So it's good to see. When that presentation was going on, I was very alert, and it was very interesting for me, because it's something I've done before. So, but since I am practicing to be an obstetrician, it's nothing I really see much, yeah, because generally see pregnant women with diabetes, and that's my specialty now.
My name is Max Boy. I'm a consultant general and laparoscopic surgeon based in Nairobi. I'm in private practice. Mostly I'm a general surgeon, but I have an interest in diabetic wound management. This conference is of particular importance because it has brought us all together, different specialties, to discuss how to manage diabetes in the country as a multidisciplinary team. As one of the non-communicable diseases that are rising in the world, it's important that we have such conferences not only in Nairobi, but all over Kenya, so that we can always put our heads together in terms of management of diseases such as diabetes, which are easily controlled, but require many people to come together in one forum to discuss their various experiences. Okay, for me, what I'll take home today is we need to all work together, not only in our small practices, but communicate, refer patients early, develop a referral system whereby if a patient has a particular complication that cannot be handled at one particular level of hospital care, you have a network whereby you can easily refer the patient or refer the patient to, so that they can be put in contact with the doctor or the health practitioner who will be able to help them.
Okay, my name is Maurice Ochieng. I'm diabetic, 39 years of age. I stay here in Nairobi, and I'm working with the Kenya Defeat Diabetes Association, that's the KDDA. My main aim of coming to this place is to learn a lot from where I've learned. Main aim with the KDDA is not about medication. It's about nutrition, exercise, stress management. So what we do here in Kenya mostly is that we perform or we make support groups across the country. So far we've done 15 counties, and we are doing well. I can say so because each and every year we make sure that we make more than 10 counties. So diabetes is a major disease that is affecting our people. To us, we don't say it's a disease. We say it's a condition because you can manage it and live with it for long. Myself, I've lived with it for over 10 years, and I'm still going strong. So our main aim with the KDDA is just, we get to the ground, teach these people what are the things that you need to do so that you can live a very positive life. So with the nutrition part of it, we normally say that 60% is your medication. So get the 60%, get 20% on exercise, and get 15% on stress management. The remaining 5%, we leave it to the doctors. So that's what normally we don't only do in KDDA. And that's my main aim of coming here, to get more knowledge, to that something that maybe I've not received yet.
My name is Betsy Odundo. I am currently practicing in an Aga Khan hospital, one of the tertiary hospitals in Nairobi. I'm glad to have attended this conference, or rather interaction seminar. We are seeing a lot of diabetes in Kenya of late, and not only in Kenya, in the outside world, because of our lifestyle changes. So it means management is going to change. Lifestyle advices are going to be taken seriously, like food, it's no longer, it's cool nowadays going to the gym. It's no longer, it's not cool again going to the gym. You have to go to the gym, or you have to exercise, you have to jog. The whole idea about me attending this session is about the latest management that currently, maybe we have been doing some stuff, but we have all the time. Health field is dynamic. You have to top up what you have every other time. You have to drop some of the practices that you have been doing that you no longer need. So in a nutshell, I'm happy. Whatever it's being presented to us, it's what we are using for current management, and we encourage the young ones and the people who participated, and the people who are convening this convention to again do it, so that we are up with our game in the management of diabetes. Thank you.
My name is Dr. Khadija. I work around in Nairobi. I think it's been a very fruitful morning. The questions that were raised by the panel were very engaging, and we've basically had to learn a lot. Yeah, so I'm grateful to be here. Yes.
So what did you pick from the session that I just attended?
I think for me it was the preconception management. Yeah, that's something that hadn't really crossed my mind, the impact that it has. Yeah, so it would have to be that.
Okay.
Yes.